Your subjective assessment is one of the most important parts of your assessment. If you listen to the patient long enough, they'll tell you what the problem is, and if you listen for a little bit longer, they'll tell you how to fix it. We'll aim to highlight some of the key points to streamline your objective exam for even the seemingly most complicated patients and to create raving patients that will promote you to their family and friends. Let's consider the case of Lana. Lana is a 36-year-old with a 5-week history of worsening right side bum pain. That's her P1. It began after twisting to put a stroller in the trunk of her car, and she can't seem to find a comfortable position. She's nursing and so hasn't been taking medication. Her husband suggested she exercise, and so she started doing some CrossFit exercise, and now she's noticing groin pain, which is her P3, and leg pain, which is her P2. Aggravating for her are any positions for too long, and that aggravates her P1, walking quickly, which is P2 and P3. Easing factors include changing positions for P1, although nothing seems to help. In general, there's always a baseline level of pain, and she feels like things are getting worse. From a medical social perspective, she's postpartum for 4 months. 6 years ago, she threw out her low back moving a bed and hurt for a few weeks, but then managed to get better. During her pregnancy, she recalls she had ligament pain in the bum area, and a chiropractor thought it was a hip strain. She also had pain in that area during labor, but it was manageable. She tried doing more intense exercises, and this started to increase the pain in her right glute to her lateral knee, and it created a trigger point in her right lateral thigh. So that's a lot of information to digest. At this point, I'd like you to pause the video, and I'd like you at this stage to write down a list of potential sources of pain for each of Lana's P1 to 3. Now, some of these may be unique and some of them may overlap. So I'd like you to pause the video at this time and just to create that list. Hopefully you've come up with a pretty exhaustive list of things that could be creating pain in Lana's P1 to P3 areas. And one trick of trying to come up with this list is to think for each of these pain sources, what could be the local structures in that area that could create pain. So for example, her lateral thigh, her groin, and the glute area, but also structures that can refer pain. So when we think about local, we're thinking about joints, muscles, and nerves. And when we're thinking about referred, those can be the same thing. So when we start thinking for Lana about what could be her potential sources of pain, my list includes joints, and that could be local for her lumbar spine joints, and that could be the lumbar spine joints, ligaments, or discs. And if we start thinking about localizing that down to a smaller number, that could be about the L4 to S1. We know that that would refer potentially into that glute and lateral thigh area. We also do know that the upper areas of the lumbar spine and lower areas of the thoracic area can also refer to that gluteal, lateral thigh, and groin area as well. We have locally the sacroiliac joint, and we do have the hip joint. When we start thinking about local muscles, that could include gluteus maximus, medius minimus, piriformis, gemelli, obturator, internus, and externus. We do have the hamstrings, the tensor fascia lata, the adductors, and the psoas. And we could also start thinking about potential referrals of the nerves from the S1 to S4, the gluteal nerves, and the upper lumbar nerves, which become cutaneous over the glute, the lateral thigh, and the groin, are sometimes referred to as the cluneal nerves. Now, that's a pretty exhaustive list of potential structures we might have to rule in and rule out. So what additional questions might you ask to help narrow down this list to hopefully a more manageable 3? So if our patient hasn't already given us the information, we may want to find out about things like the mode of onset. Was it sudden or insidious in onset? Did it occur with trauma? Because we know pelvic pain as well as low back pain can occur with episodes of trauma or insidiously. Was this the first episode, or was there a previous history of pain? Was there a recent history of fall onto one leg or onto the buttocks? We know that the pelvic joints are very strong in terms of rotational forces, but they are vulnerable to shear injuries. And sometimes these shearing injuries can occur in the months to years prior to an onset of pain if something changed from an exercise perspective. We can also ask about questions related to pregnancy and the type, vaginal versus cesarean, different weaknesses of the pelvic floor may exist, as well as the potential for scar tissue. How does her pain behave? Is it located over the sacroiliac joint? And if it does, is she able to point to it with one finger, which would be our fork and finger test? Or is it more broad where she has to point with it to our hand? When pointing with the finger, it's more indicative of potentially long dorsal ligament pain, whereas it doesn't tend to be when they have to point over a larger area with their hand. Does the pain influence one area and the other? Does P1 always occur with P2 and P3? Does it radiate into the legs? Is there any aggravating activities, which Lana did discuss for us? What is the effect of walking, stair climbing, rolling over in bed, getting in and out of a chair, or stepping onto a curb? These are all pelvic rotational type of movements that often aggravate pelvic pain. What is the effect of coughing, sneezing, and Valsalva, which might be making us think a little bit more of discogenic types of pain? And does it improve with rest? If it's improving with rest, from a time frame perspective, we're starting to think about a more mechanical type of pain. If it doesn't fully resolve and it tends to have a underlying pain, then we might be starting to think about something more inflammatory in nature. How the patient describes the pain can also give us an indication of what is the potential source of pain. Vascular pains are often described as throbbing, pounding, pulsing, or beating, whereas neurogenic pains are often described as sharp, crushing, pinching, burning, gnawing, jumping, or electrical. Musculoskeletal pains tend to create sorenesses, heaviness, hurting, dull, cramping, or very deep types of pains. And sometimes we may encounter patients that are telling us of tiring pain, a miserable, it's vicious, it's agonizing, nauseating, the pain is punishing, killing, or sickening me. And that's often when there is an emotional overlay to their pain presentation. It doesn't mean that they're faking this. They often will truly have a pain, but there may be secondary factors that are contributing to how this pain is being perceived by themselves. Not all pain or problems will fall under the umbrella of physiotherapy management. In the middle, we have potential discogenic type of pain and facet type of pain, but there are the insidious that will require more medical intervention. These range from cauda equina syndrome to infections, to tumors, to fractures, as well as inflammatory types of pain. Now, we know that although not common, these can be potential sources of pain that we do have to consider. Studies suggest that the incidence of these types of problems, these medical management problems in the average patient population with low back pain are only typical in about 5 to 10% of the population. So, but even though they're low, we know that they can be present and we can typically rule these out by asking the right type of questions. If we can rule out these sinister presentations, then we can focus on our bread and butter. So what questions would you ask in your subjective exam if they aren't already presented to you by the patient to help to rule out these sinister conditions? I get you to pause the video and just think of the type of questions that you would use to rule out cauda equina, tumors, infection, and inflammatory conditions. To rule out inflammatory conditions, we want to determine if acute symptoms are presenting beyond the typical inflammatory time frame. This is often an acute low back pain that's presenting for more than 3 months. There's typically no traumatic injury. Pain is worse at night and will often wake the person up in the middle of the night with pain. They typically report a good response to anti-inflammatory types of medication, even though again they should be past this inflammatory period. On more specific questioning, they may indicate a personal or family history of other inflammatory conditions that include uveitis, Crohn's, celiac disease, psoriasis. They may have also had blood work that may have actually found the presence of human lymphocyte antigen B27. They may have a family history of also spondyloarthritis. So questions we could ask include things like, do you have Crohn's disease, celiac disease? Does anybody in your family have these conditions? Have you ever had a swelling of the eye, which would be uveitis, where it turns completely red? And we have an image coming up in one of the other slides. As they start saying yes to these types of questions, it starts increasing the likelihood that we're dealing with an axial spondyloarthritis. We know that HLA-B27 is typically present in about 5% of the population. However, in inflammatory conditions, they tend to be present in 95%. So its presence doesn't necessarily mean that they have an inflammatory condition, but it's more likely that they do when that's present. And here we have some images showing some of the peripheral manifestations of inflammatory conditions. The image on the left is showing an enthesitis of the Achilles tendon, where you can see that there's a thickening that happens right at its distal attachment. The picture on the right is showing dactylitis, in this case of the finger, but it can be of the toes as well. And it's a sausage-like presentation of painful inflammation to the entire finger or toe, and it's going to swell uniformly, not just localized to a joint. And the bottom image, we have an acute uveitis, which is unilateral, reddening, spontaneous remissions, and it can be recurrent, and it's often related to HLA-B27. So in thinking about a rule of thumb criteria for the diagnosis of inflammatory back pain, the modified criteria, the Berlin approach, is showing that when we start thinking about people presenting with inflammatory back pain, typically they're under the age of about 45 to 50 with a 3-month history of low back pain. And in conjunction with that, complaining of morning stiffness lasting more than 30 minutes, improvement with exercise, not with rest, waking up in the second half of night because of pain, and typically alternating type of back pain. Inflammatory back pain is present if at least 2 of the above parameters are fulfilled. And here we have a table just mentioning some of the other insidious type of presentations that could occur. In the case of cauda equina symptoms, we'd be expecting that the key subjective would be bilateral leg pain. We would be expecting saddle paresthesia, so can they feel when they're wiping with toilet paper? And are they getting overflow incontinence where they're leaking feces out? Now, typically when we're talking about cauda equina syndrome, that would be feces and urine. We know that it's not uncommon for people to have urinary continence, but fecal incontinence should be a flag. For infections, we are thinking people that have had recent surgery, immune suppressed, and specifically high fevers with a new onset or a different type of worsening back pain. In the case of tumors, we know that primary tumors in the spine are quite rare. However, if they've had a past history of cancer or they're younger than 20, primary bone cancer can be common. We were typically expecting that they're going to have unexplained night sweats and unexplained weight loss, and that's typically more than 5% of weight loss in 6 months. Fractures tend to be traumatic in onset, accompanied with osteoporosis, and the pain is often in the upper lumbar, lower thoracic region. Typically with women, that's going to become related to osteoporosis, past spinal fractures, or corticosteroids. In the absence of those, we're thinking more of the findings associated with potentially discogenic or flexion aggravated type of pain versus facets, which are more of the extension types of pain patterns. So if we've excluded the sinister stuff, what are the seeming more likely or less likely to be the case for Lana? Well, it wasn't really part of this case, but clinically, as we get to the objective, how can we shorten this list? Will the subjective areas discussed be enough? The distribution of pain could give us a hint of what's going on, and we could start thinking about our dermatomal maps and where the patient is complaining about pain. Garrett developed the most widely used dermatomal map in 1948, and they studied specifically presumed single-level disc protrusions in the cervical and lumbar spine. In the lumbar spine, 1,264 patients with presumed single-level disc protrusions, 707 of which were verified by surgery, were evaluated for diminished cutaneous sensitivity. These sensory findings were used to create dermatomal maps, and modifications of this dermatomal map are routinely used today in clinical settings. The image on the left is based on the study by Furman et al., where they were using 125 fluoroscopy-guided lumbosacral transforaminal epidural injections with symptoms locations noted and then combined to create a composite, specifically looking at where the pain was before and where the pain was eliminated. And as we can see, pain distribution does not always follow pure dermatomal maps. We will find our dermatomal findings positive, but when typically a nerve root is involved, we're talking about the most common presentation being the back of the leg, regardless, or the entire leg, regardless of the level of the disc involvement. In considering discogenic pain patterns, we're hoping that a person with a discogenic or flexion aggravated pain will tell us exactly that sitting bothers them, that standing up feels better. But keep in mind that these people, that when they do centralize their pain, those lower down symptoms as they vanish will often make them feel more localized pain higher up into the back or into the leg. This may give the patient the impression that extension is bad and that flexion is better because it's referring further down the leg and getting lighter. And we're going to be using appropriate verbal cues as we're performing our objective assessment to make sure that we're getting the right answer. So conversely, when we start thinking about extension pain patterns, one of the common sources of pain will be our facet joints. Pain is often localized to the back area, but can refer as far away as trochanters, glutes, hamstrings, calves, or even into the feet. However, the pain doesn't tend to be linear. It tends to be patches of pain that correspond to the innervation of these facet joints. The patient will often describe a pain presentation that they experience when standing, bending backwards, or carrying heavier loads in front of them in that extended back position, but we can't always rely on the location of the pain to tell us the level of the joint involved. This particular study was looking at patients with chronic low back pain who underwent a Z joint injection or radiofrequency facet denervation, and these were the ones that were being studied. Under fluoroscopic control, the joints from L12 to L5S1 were stimulated by injection of contrast medium, and the lumbar medial branches of the dorsal rami from the 12th thoracic area to L5 underwent electrical stimulation during the facet denervation to look at referral pain patterns. And as we can see from this table, the upper lumbar spine, especially looking at the level of L23, can refer down to the gluteal trochanteric lateral thigh area, and we can see a similar pattern when looking at the median branches of the L1, 2, and 3, that they can also refer to that gluteal region as well. So don't rely on the location of pain to determine the level of the joints that are involved. And a similar study that shows in a little bit more color what we're talking about, that when we are talking about low back pain specifically coming from these joints, that when it comes to their common referral pattern, we know that they will complain about the back, but that where they refer down into the glute, posterior thigh, trochanter, lateral thigh, that can vary broadly across very many segments. So linking this back to the case of Lana, the current subjective information that we have doesn't sound like we're dealing with cauda equina syndrome, tumors, or infection. The absence of low back pain makes it less likely that we're dealing with something facet in nature, but there may be an underlying inflammatory issue involved, especially with her being recently postpartum and at only 5 weeks, she may not have passed into that mechanical stage yet. In summary, your subjective assessment is one of the most important parts of your assessment. If you listen to the patient long enough, they'll tell you what the problem is, and if you listen a little bit longer, they'll tell you how to fix it. We want to rule out sinister pathologies through specific questioning, determine the stage of healing based on their onset of pain, which will tell you whether you're teaching the patient how to reduce their pain, touching base with their doctor with respect to anti-inflammatory medications, or if you can make a more quicker improvement because they're in more of that mechanical stage of injury. Use aggravating and easing to help differentiate spinal flexion aggravated pain, spinal extension aggravated pain versus pelvic pain. And most importantly, set yourself up to do a more complete objective assessment by ruling out some of the extraneous factors. Patients are paying us to assess, not to guess.